Today's topic is safety, activity, and immune correlates of anti-PD-1 antibody in cancer. So definition. Program DEF1 PD-1 is a key immune checkpoint receptor expressed by activated T cells and it mediates immunosuppression. Let's see the media. It takes a little bit.
Hello and welcome to EJC News Focus. EJC has just launched an annual Drug of the Year article. The winner for 2013 is not a single drug, but the anti-PD-1, PD-L1 antibodies chosen for studies presented at ASCO, which changed the minds of many oncologists on the potential for immunotherapy in cancer. I've come to the IGR in Paris, where I met Jean-Charles Soriot, who has been using the antibodies in lung and other cancers. I asked him how they work.
In patients with cancer, the tumors evade the immune system. And the blockade of PD-1 or the blockade of its ligand will allow lymphocytes to again recognize the cancer cells, attack them, destroy them. That is the rational basis of this new approach.
Caroline Robert, also at the IGR, has extensive experience of the antibodies in melanoma.
On the site of the metastasis, very often we see lymphocytes, but they are not able to produce interferon, they are exhausted. And we have weapons like anti-CTLA-4 antibody that help us to fight against the tolerance. So they will activate, like if you compare it to an army, they will activate like all the soldiers, even the ones which are not going to be very specialized and very effective and very targeted against the cancer cells. So this is why probably we are less effective and we are more autoimmune toxicity, because we activate the immune system in a very unspecific way. And then with anti-PD-1 and anti-PD-L1 antibody, we are going to reactivate the lymphocytes, and if I continue my army metaphor, it's going to be the snipers, the ones who are already in the tumors because they are already specific for the tumor-associated antigens. They are on the site where they have to be, but they are like too tight.
PD-1 and PD-1 ligand represent rational targets for an approach that will allow the host, the patient who is bearing a solid tumor, to trigger again his immune system against the tumor. This is an approach that is not individual based. There is nothing such as using the tumor of the patient or creating a vaccine. This is really a commercial compound or something that aims to become a commercial compound that is represented by monoclonal antibodies. So ready to be used in patients as an IV shot.
Why was it chosen this year specifically? Has there been a rush of new results?
Clearly, because this year it was the confirmation year of the fact that the blockade of this axis is working outside the classical setting of activity in what we consider as immune-related tumors, melanoma and kidney. We do have now clear proof of concept and clinical activity in solid tumors where immunotherapy never had experienced such a degree of activity. And we can take the example of non-small cell lung cancer, which is a disease where most oncologists and thoracic practitioners would consider immunotherapy as an approach with no activity.
How effective is this approach then in solid tumours?
There are four main antibodies for which we do have some results. There are compounds that are able to block PD-1. This is nivolumab and lambrozilumab. And there are two compounds that block PD-L1 that still go by code names, BMS 559 and MDPL3280A. What do we know now is that with nivolumab, objective response rate was obtained in 30% of patients with squamous cell carcinoma, 33% to be precise, and around 12% in non-squamous. That was already published last year. With BMS 559, which is the PD-L1 blockade antibody, response rate was lower in the range of 8 to 11%, but interestingly enough, survival rates at 2 years in metastatic non-small cell lung cancer with squamous histology were reported to be 44%, which is unheard of in that disease. Then we had data this year at the ASCO meeting with the MDPL3280A in around 52 patients with non-small cell lung cancer, and their objective response rate was reported to be a single agent in patients that were as high as 3 or 4 lines of therapies, 22%.
Just how strong are the results in melanoma?
So
You know, melanoma is a disease.
this part of the video will explain in another video coming up. So application in medicine. This trial is important for medical research because it can find a solution for cancer patients. Let's see this video.
Suzanne, thanks for coming to see us at eCancer TV, because this whole question of anti-PD drugs and looking at some of the quite sophisticated processes going on inside cancer cells and how they affect the environment. You've been using nivolumab. What were you doing with it, and in which setting, and why?
What we're reporting on here at ASCO is the results of a phase 1 trial of nivolumab with expansion cohorts. So it's actually a fairly large trial of about 300 patients with 5 different kinds of cancer, including melanoma, lung cancer, kidney cancer, colorectal, and prostate cancer. And the idea of the trial was to block a molecule that we call an immune checkpoint, in this case programmed death 1, PD-1, in order to reactivate immune responses against cancer.
In fact, the tumor is holding the body's immune systems in check,
Exactly
and
right.
you're removing that whole.
So it's along the same lines as what has been discussed before for anti-CTLA-4 or ipilimumab, which was approved 2 years ago in the United States for treatment of patients with advanced melanoma. This study goes beyond that to examine patients with other kinds of cancers, and what we found were substantial response rates in lung cancer and kidney as well as melanoma.
Okay, I'd like to ask you about that, but could you tell me about the study, what you did and what sort of patients you had?
Right. So these were all patients who had at least one prior treatment for their cancer, but about half of all the patients on the trial had 3 or more prior systemic treatments for their cancer. So they were a heavily pretreated patient population who came onto the study, which was designed to test the safety and tolerability of nivolumab. And so early on in the trial, as per standard phase 1 trials, they were recruited in small groups of patients at increasing dose levels. We did not find a maximum tolerated dose or dose-limiting toxicity. And then at that point, additional patients were enrolled to learn more about the safety profile, but also to learn something about the efficacy of the drug.
Now, at this stage, is this all comers, or are there any particular types of patient or characteristics that you can look for that would be more susceptible to inhibition of PD-1?
Well, in order to be eligible for this trial, you had to have one of the 5 different kinds of cancers that I mentioned, but they were not selected. Yeah, they were not selected for any other kind of marker. So the purpose of the trial was to learn about the profile of the drug in terms of activity and safety, and to explore potential molecular markers that might allow us to select patients most likely to respond.
Now, you described the results as quite interesting, quite good. What are the data?
Well, what we're reporting on here are not only the objective response rates, meaning traditional RECIST criteria, complete or partial regressions, but also the durability of those responses, the fact that those responses can persist even after the drug is discontinued and the patient is simply observed, and the fact that those responses are associated with what appears to be favorable overall survivals. Now, this was not a randomized study, and so really, in order to say anything about an overall survival benefit, we will need information that's going to come out of the randomized trials that have already been started. But yeah, I think we can still learn a lot from this large study that we're discussing here at ASCO.
One of the thoughts that's floating to the top in use of checkpoint inhibition is that you could use it as part of a strategy, and you can actually add other therapies to it. Correct. To complete the process. How are you feeling about all this and that?
We, as a field, we think this is the next frontier. I mean, on the one hand, we're very encouraged about the fact that we can see the regression of advanced solid tumors with monotherapy with nivolumab. And we're also extremely encouraged that we're not just seeing this with nivolumab, but also the other drugs that are being discussed at the conference from a variety of different companies that either target PD-1 or target its major ligand PD-L1. So a very consistent theme is developing that this pathway, the PD-1 pathway, is important for cancer. So how do we then go to the next level? We're helping a certain percentage of patients. We need to help more. Everything that we know from laboratory studies says that combination therapies are going to be the way to go.
Can you incorporate this knowledge into an algorithm that the everyday doctor can use and simply plug in and individualize therapy?
I think that really this needs to be studied in a systematic way, based on solid evidence from the laboratory, rather than picking and choosing, drugs of convenience and so forth. I think.
But are you at the stage where you've got enough knowledge to think about having an individualized treatment based on the molecular features you find and the particular pan-cancer effects like checkpoint?
I don't think we're there yet. So I think we're on the way. I think we have some interesting leads, but it requires a lot more study, and this is what we are doing now in the next generation of clinical trials.
And how would you summarize what doctors should be making of nivolumab and these results you're quoting here at ASCO?
I think that these are still early results, but that there is reason for a lot of optimism that this kind of approach, modulating immune responses against cancer in an outpatient regimen that seems to be fairly well tolerated, this kind of approach is here to stay, and the next level now is going to be to increase the efficacy by adding other drugs to the regimen.
Suzanne, thanks for joining us on eCancer TV.
My pleasure.
So let's continue. Pros and cons. Pros. Anti-tumor activity was observed at all doses tested. The anti-PD-1 antibody acts very fast, 1 to 4 hours after the start of infusion. Cons. Adverse effects were fatigue, decreased appetite, diarrhea, nausea, cough, dyspnea, rash, and headache. So let's see this video, which is like a continuation of the another one, of the
We've
first
seen
one.
clinically meaningful activity in a substantial number of patients. And as we have now a series of 135 patients followed between 7 months and a year and a half, we can start to get a sense of what's the response rate and the durability of response. The overall response rate by RECIST criteria with confirmation of responses is 38%. The great majority of the responses, 90%, are durable up to date. The patients have not progressed. There's different dosing regimens, and at the highest dose cohort, the response rate by the same criteria is 52%, which tells us that we're getting with a single agent immunotherapeutic, something that doesn't do anything to the cancer but stimulates the immune system. It's getting to levels that we can never come before. The drawback is minimal. There's most of the treatment-related adverse effects are grade 1 and 2, diarrhea, skin rash, fatigue, and pruritus. In grade 3 to 4 events are minimal. They're, we call the whooping number, there's 12.6%. So that's a very low frequency of grade 3 to 4 adverse events compared to any other therapy that we use in oncology.
So, disease. Cancer is a group of diseases involving abnormal cell growth with potential to invade or spread to other parts of the body.
One out of 5 people worldwide will develop cancer at some point during their lifetime. Cancer can affect every part of the body. Cancer is a collective term for a big number of diseases in which body cells multiply out of control. Normal cells divide and multiply so the body can grow or to replace old and damaged cells. When cancer occurs, cell division becomes unrestrained while there is no need for it. Besides that, the cells that form have an irregular shape and can't function well. These cells can form into a solid mass called a tumour. If the tumour doesn't influence nearby tissues, we call it a benign tumour. If the tumorous cells also invade the nearby cells, we call it a malignant tumour. Only malignant tumours are called cancer. Malignant tumours tend to spread to other parts of the body. This happens because tumorous cells break off from the tumour and spread through the bloodstream or lymph channels. The tumorous cells form a new tumour in another part of the body called a metastasis. What causes cancer is unknown, but there are certain risk factors that increase the chance of getting cancer, like smoking, drinking a lot of alcohol, too much sun exposure, unhealthy diet, certain carcinogens like asbestos or radioactive radiation. Cancer cannot always be cured. A successful treatment depends on location, type, how far it has spread, and the rate of growth of cancer. Cancer is often treated with a combination of surgery, chemotherapy, and radiation. This may differ for each patient and type of cancer.
Next. So symptoms. It depends on the type of cancer. For example, lung cancer can cause blockage of the bronchus, resulting in cough and pneumonia. Causes. The great majority of cancers, some 90 to 95% of cases, are due to environmental factors. The remaining 5 to 10% are due to inherent genetics. Prevention. Prevention can be achieved by diet, medication, or vaccination. Let's see this last video.
Welcome to Personal Care Physicians TV. My name is Dr. Jeff Barkey. You know, a funny thing the other day, a group of us in the office were playing the lottery. And it got me thinking about a patient that came in and asked a question. This was a 48-year-old overweight male And he wanted to know, was there a supplement, a pill, some sort of intervention that he could do to prevent himself from getting cancer? It made me think about the genetic lottery, if you will. My belief is the following. Some of us are genetically blessed. Smoking, drinking, lack of exercise. We're going to live to be 100 or so. Some of us are genetically cursed. That is, despite our best effort in taking care of ourselves, bad things are going to happen, sometimes at a young age. For most of us, however, we're somewhere in the middle. That is, how we take care of ourselves is going to determine that genetic expression of disease. So for the majority of us, here are 3 key important elements in preventing disease and ultimately preventing cancer. Number 1, and most important, eat an anti-inflammatory diet. Growing evidence supports inflammation as the foundation upon which disease occurs in our body. Our nutrition is directly related to inflammation. Avoid the following to prevent inflammation: processed foods, animal fat, cheap vegetable oil, simple or refined carbs such as bread, pasta, rice, sugary foods, and of course, alcohol. Instead, eat a Mediterranean or zone-like diet with lots of fresh vegetables, fruit, lean protein, and healthy fat. Add fish oil to your nutrition to further help reduce inflammation. Number 2, exercise almost every day. Exercise helps both mental and physical health. It does not have to be complicated. Even a 20-minute daily walk can make a big difference, so you have no excuse when it comes to exercise. Number 3, get plenty of sleep. For an adult, at least 6 hours a night is needed to help our bodies rejuvenate. Poor sleep is associated with high blood pressure, obesity, diabetes, and other illnesses as well. My advice is not rocket science, yet most of us avoid these simple principles. For more information on medical, fitness, or nutrition information, please visit us online.
I love this last video. So, thank you very much for your attention and see you next time.